in-person session. We will have virtual attendees, so it's not screen, just as you're aware. And the session we're here for is creating safe spaces in unprecedented circumstances, extreme heat and the pandemic, homelessness and healthcare. So it's healthcare and homelessness, creating safe spaces in unprecedented circumstances, extreme heat and the pandemic, homelessness and healthcare. So I'd like to introduce the speakers. We have Magdalena Fire, as well as Michael Schwartz taking the first session for the speaking too. After which Kate and her team, Fred and Bailey, will take the second session. But before we proceed, I would like to read the land acknowledgement, and I would also like to say upfront that we please forgive me if I may get pronunciation correctly. So we acknowledge the land we are meeting in on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse populations, Inuit and the Métis people. We also acknowledge that the city of Toronto is covered by the Treaty 13 with the Mississaugas of the Credit. I would like to say on this note that Magdalena and Michael are the session. Thank you.
Thanks for that introduction, and thanks for joining us for this session. I'll stand here at the podium, as well as being a bit more dramatic. It allows me to see the screen a bit more. I'm Michael Schwant, Medical Health Officer at Vancouver Coastal Health, and my colleague Magdalena and I will be presenting a little bit about the extreme heat response in BC in 2021 and events around that, and then some of our preparation for this year and for subsequent seasons as well. There's no slide advancer here, so I guess that I'll just ask for the next slide when it comes up. And I really appreciated the acknowledgement of the land that we're here on, especially as a visitor from British Columbia. Thank you for that. Next slide, please. Just as a quick outline, as I mentioned, I'll give the health perspective from our public health unit in Vancouver, and then hand things over for the perspective from social housing, from BC Housing with Magda. On to the next slide. Thanks. And then just an acknowledgement of the land that we work on, where I work in Vancouver Coastal Health. It's on the unceded territories of 14 different First Nations. I think that in the topic of extreme heat impacts and health, this is very important to mention. We know that processes of colonialism and systemic racism put different populations at risk, including Indigenous populations. The very issue of climate change that is driving this to a large extent is the result of extractive and colonial processes in many cases. So I think that this land acknowledgement really lands heavily with me whenever we're talking about climate change and health and the impacts of extreme heat. Next slide, please. So just quickly, we'll talk about 2021. So that's just over a year ago, of course, the BC heat dome, as it's known, and some of the health impacts from that, and then talk about what we did after that, some of the action that's been taken since then. Next slide, please. Some of these are really just transitional slides, you'll see, so we can move on. BC heat dome of 2021. So this was 7 days, June 25th to July 1st of that year. And you'll see on this map here a lot of numbers starting with 4, a lot of temperatures in the 40 degrees, dozens, over 100 single-day temperature records were broken in southwestern BC during this time. We don't often see temperatures in the 30s in southwestern British Columbia, so temperatures going into the 40s, truly unusual. And for it to be this sustained and without overnight relief was something that was really impactful for indoor temperatures, where most people spend most of their time. We found temperatures through some of the research that was done, through anecdotal reports, into the mid-30s or even high 30s in people's homes, because we just don't have in British Columbia the housing stock that's prepared for this kind of weather. Next slide, please. And quite tragically, the impact of this was the death of many people within our area. A report by the BC coroner found that 619 deaths were thought to be due to extreme heat. I would say that that's probably a conservative estimate. We know that excess mortality can be higher still when there's conditions like heart disease, lung diseases, and others that can actually be exacerbated by the heat. They dug very carefully into deaths during this time to try to determine if they were caused by heat or not. But I think that 619, that's a very firm basement, if you will, for the true and really tragic toll that we saw. Next slide, please. Following that, the Coroner's Office of British Columbia did conduct a report into these events. You can see the title there. This was a death review panel that was convened. Magda and I were part of that process. People from a number of different organizations trying to examine what had happened, what had gone wrong that allowed this many deaths to happen, and importantly, what actions could be taken to mitigate against that kind of impact in the future. And on the next slide, I'll just pull a few of the key findings from this. First of all, age was a massive risk factor. We found that people in older ages, particularly 60 and over, did make up the large majority of people who passed away during the heat dome. We know that young age, so young children and infants, can be at risk for hospitalization, for needing to go to the emergency room, for heat exhaustion, but we saw no deaths at all in people under 30 in this analysis, although I should note that their illness and their need to access health services is still very important. But in terms of mortality, really it was older adults that experienced the brunt of this. Next slide, please. A few of the key findings I just wanted to pull out there, going from top to bottom here. A key issue, as I had mentioned, is that people lacked access to cooler buildings or air-conditioned spaces. Air conditioning, particularly in coastal areas of British Columbia, is quite rare in residential buildings and houses and even apartments. Commercial buildings are more likely to have it, but it's just not that common in housing at this point, as well as heat pumps or other cooling mechanisms of that nature. Elderly people, particularly at intersections with social isolation, were at higher risk during the heat dome, and as well as that, people with pre-existing chronic diseases. As I mentioned, diseases of the heart or lungs, mental health conditions, and others all seem to place people at increased risk. In fact, over 90% of people who passed away were on at least one chronic disease registry by virtue of the medications that they were using or the specialists that they were seeing. Next slide, please. Just put in a little bit more just of a simplified slide. This is from the BCE Centre for Disease Control. Again, they found that old age, social and material deprivation, isolation, and all of these other issues that I described were some of the main risk factors for death during the heat dome. And some of the protective factors, in a word, privilege, having the material wealth to be in a home that could sustain these warm temperatures, specifically having air conditioning or other cooling features, neighborhood green space, mitigating against the urban heat island that we have in many downtown areas of many cities, and being in a healthcare facility like a long-term care home also seem to be protective during the heat dome. So by definition, people who are living in long-term care or assisted living are at medically higher risk. They're more likely to have some of these other conditions on average anyway. But people who are in long-term care homes were actually, relative to their age-matched peers, less likely to pass away during the heat dome. So this does give us, I think, some indication that when there's on-site support, looking into people's space and how they're doing in terms of their own health status, that it's not a given that people with these risk factors are going to have severe outcomes. This can be mitigated, we believe. Next slide. And this is just to say some of these risk factors are well known already. Vancouver Coastal Health, working with colleagues at University of British Columbia, had looked at some issues like the green space or lack thereof, the paved surfaces at different parts of our community, the age, presence of chronic diseases on a neighborhood by neighborhood level, as well as the expected temperatures in different areas, and tried to characterize that risk around Vancouver. As you'll see, these darker red areas are where the risk was thought to be the greatest when the study was done over the course of 2019 and 20. In terms of where we saw people coming from at a neighborhood basis, this is a heat map sort of blurring people's home addresses where they had come from. Some of those same areas were the most affected. So people who know Vancouver will see right away here, we have the downtown east side as one area, other parts of downtown Vancouver too, not only the downtown east side, and also southeastern Vancouver, which has been noted to be an urban heat island and also an area where some of these social risk factors are more concentrated in many cases. So this is risk factors that are actually pretty well understood in terms of the global research data on heat illness during these events, and it does allow us to intervene. Next slide. What sort of homes were people in? Again, most of people who had these, what they called in the coroner's report, the place of injury where they experienced the heat. They may have passed away in a hospital or another site, but they were referring to in this table where people were when they were affected, when they were impacted by the heat. most people were indoors and for the most part in their own home, roughly evenly divided between multi-unit buildings and detached homes, and a variety of different typologies, everything from small apartment buildings to high-rise towers, and that detached home could be someone's owned home or a house that was cut up into several suites. So these are very broad categories, really. They did look specifically at the count, a very large and important portion of people who are in single-room occupancy, social housing, supportive housing. Many of these buildings were found to be quite hot during the heat dome. And Magda might talk more about some of the work we've done to study that and look at some of the factors we can use to protect those buildings, as well as a number of other settings. So people living in trailers, mobile homes, RVs and campers. Given the affordability crisis in Vancouver and surrounding areas, a number of people are residing in these informal kind of structures, and this actually did contribute a large number of people who, again, really tragically passed away. Next slide, please. So talking a little bit about with some of this data, again, very fast tour of it here, some of the things that we've done as a sector in public health and with partners over the months that followed that. Moving to the next slide, please. Some of the key areas from the death review panel, 3 key areas, each of which with a number of recommendations, was one, a better coordinated provincial response. We had this issue that a number of people didn't know that we were in the level of emergency that we were in. The messages of what people should be doing, either as service providers or as individuals to support their communities, weren't clear. This is feedback that was given, I think, loud and clear in the months that followed. Ensuring vulnerable populations are actually understood, identified, and supported during these events. We actually know pretty well, again, those 2 maps that I showed you show that there's actually a pretty good sense of where the risk might be. This is not, I think, a matter of much scientific mystery to go and find where people might be at risk, but the actual interventions that are going to be supportive can be more challenging. And then actually taking preventive, long-term risk mitigation steps. So not just reacting during a heat event like this, but thinking what can we do in terms of the housing the people are in, the services and supports that are available. We joke that we're here in November having a meeting and talking about extreme heat, but this might actually be the most important time of the year to be talking about these issues because that long-term planning is so important. On the next slide, please. Another really important report, and I would say, we've heard, through the meeting, and we've, I think, tried to apply in much of our work the idea of nothing about us without us when we're talking about populations who might be at increased risk for, a given issue, people who are put at risk by societal decisions. This is a report that the Climate Action Secretariat in BC had commissioned to look at the lived experience specifically of people with disabilities, older adults who are economically or socially vulnerable, people with mental health or addictions concerns, and other identified groups who were at risk for death during our own heat dome or in some of the literature from other places. So they used a variety of methodologies, including focus groups with service providers, sharing circles with people with lived and living experience, one-on-one interviews in some cases to try to get some information, both quantitative and qualitative, on what had happened specifically during the heat dome, producing some recommendations going forward. So I've tried to pull a few of these on the next few slides. If we can just jump into the next one. Could we just go to the next slide, please? Thanks. One of the themes was around coordinations and communication. So as I mentioned, this was a truly unprecedented event in BC. There were plans on paper, and I think as we say in public health or maybe in some other organizations, there were plans, they were in the binder was on the shelf. And I think that people, in many cases, in theory, there was a plan that could be applied, but it wasn't well understood by the people who needed to know of its awareness, and certainly not always by the service recipients, if you will. So these are quotes from people who either had direct experience of some of these risks or were service providers in that area. People saying, I won't read every word of these, but there's a lack of awareness about how to recognize heat injury or what to do about it, how to check on your neighbors. So you see this latent desire, in fact, to look into help, but that lack of information or empowerment to do so. And as well as this feeling from a service provider that there wasn't much planning, it was all hands on deck, minute by minute. Working in public health, I think that this is a pretty fair assessment from someone who is a service provider at that time. There's a lot of scrambling, a lot of trying to figure it out as we went, which is absolutely the way that we don't want to be acting in an emergency situation. On the next slide, please. Housing, very important factor when we talk about these underlying risks. We have someone here describing that one of the most important things that they could see would be government support so that they could actually cool their own place. I mean, when we talk about some of these emergency responses that I'll dig into, ideally speaking, we should be preventing people's living spaces from being this hot in the first place. And we have this very open call for the idea of a subsidy or other programs to support that to begin with. And then as well as that, it's not just the provision of air conditioning or the availability of it, but looking at the relationship between a tenant and a landlord or their building or operator, people saying that they couldn't even use air conditioning if they had it, that there were rules saying that you couldn't put a portable air conditioner in for a number of reasons. You couldn't run your cooling for a certain number of hours. So people were actually in a position where they were scared of being evicted from the housing, often pretty hard fought to get into their housing, because they were literally scared to cool off their place, or they were directly prevented from doing so in some cases. Next slide, please. Access to cooling spaces. So cooling centers, I think a important but absolutely not sufficient part of the response to extreme heat for a number of reasons. They are definitely not the perfect response for all potential people placed at risk. First of all, you have a lot of good examples here. Someone saying, I can't go to this. Where am I going to take my things? Somebody who has insecure housing, who isn't able to leave doesn't have a space to leave all of their things. And the idea that they're going to experience stigma, municipal staff are saying that they're not trained to deal with those people. A lot of these issues, I think, really came through loud and clear in this consultation, including people noting that even outdoor spaces, even green and blue spaces near the water or in some of our parks in British Columbia, people can't comfortably access and spend long durations of time there without being needing to move along, whether that's due to stigma around people who are underhoused, racism in some cases is described, I think a very real experience. So again, when we think of just saying, get to a cool space, here's a map of them, that's not enough. We need to think of how we manage and program those spaces, and then also how can we prevent people from needing that intervention in the first place through interventions at the level of their own housing. Next slide, please. This is the last of these ones from this lived experience report. People just saying that this note that people were reluctant to reach out for support in some cases. A lot of people describe the idea that a call or an intervention from a governmental or paragovernmental organization is not necessarily welcome from some of their lived experience. People had a lot of trepidation with sharing their vulnerability or their inability to cope in their current situation for fear that they might be taken out of that situation. They might have be identified as being at risk where they were, and people did not want to destroy their current living situation. This was a risk that was described directly by some of the participants in this. And also the idea that people were trying to intervene again, but that people, by the time they got to reaching out to health services, like an ambulance, for example, it was too late. So these are people who might have known that they were at risk, but just didn't have the connection coming to them to provide the support they needed. On to the next slide. So with, again, all of that information from a couple of reports, some of the actions that were taken. Just wanted to mention, of course, we've tried to study what happened during the heat dome, share some of the lessons with that with other organizations, really improve the coordination of our guidance from public health, and I'll show an example of that on the next slide. Partnering more with the community-based sector. I think I just said next slide, but I wasn't quite ready to go to it. Partnered with organizations working on this. So much of the work in this is not just from the institutional public health sector like public health unit or a public health region, but from other organizations, municipalities, social housing, and other non-governmental organizations, and trying to better support those organizations that are doing so much of the work, often with very little margin in terms of excess capacity, if there's any at all to begin with, and then in a moment of crisis ask to go so far above and beyond, knowing that organizations like potentially municipal government, provincial government that have that capacity and that leeway to provide support ought to be doing so and can, we believe. On the next slide, please. This is just an example of this more, I think, readily understood two-step system. We had a lot of people saying in the 2021 heat dome, we did not know if there's a heat warning or a heat alert. We hear this sort of thing all the time on the Weather Channel, and we don't really know how bad it is. So a lot of people took it that it was warm out, and 3 days in, their house was 33 degrees, and you're already way behind the eight ball. It's very hard to respond and make corrections to one's space when you're suffering literally live from heat illness. So the province has created and reinforced this two-step system. These temperatures might not be impressive to long-term residents of Toronto, But in British Columbia, these are pretty hot. These are temperatures that we've found through the data actually have been associated with increases in mortality at a 5% level for the heat warning or 20% level for the extreme heat emergency. And I always say the heat warnings we expect to happen every single summer. When people ask, will there be an extreme heat emergency this summer? We'll often say, because the projected frequency is once or twice per decade, we'll say, probably not, but we have to be prepared as if it might, because at this frequency, it could happen in any given year. And these are, again, the levels where we know from research that there is likely to be increased mortality without some sort of intervention. And again, these temperatures do vary region for region. They're based on the current day's high, the overnight low, and the next day's high. And this is just because physical acclimatization is a real phenomenon, so people in different areas are differently adjusted to their temperatures. But I would say also social and infrastructure related acclimatization is also real. So areas like the interior of British Columbia, for example, due to long-term higher temperatures, are more likely to have air conditioning and some of these things in place. Some of the coastal areas or the north just are not. So their temperature thresholds are a little bit lower before we would activate that kind of heat emergency status. Next slide, please. I'm not going to read all of this to you, I promise, but the whole idea is that for every sector, for public health, for the emergency management program within the province, for non-governmental organizations, social housing, there's a fairly clear playbook. It's not meant to be prescriptive, but these are good practices that can be applied during a heat event, either at the heat warning or the extreme heat emergency level. And this was something that, again, was described as being lacking by many people during 2021. People were ready. There was some capacity to respond, but exactly what should be done was not as clear. So there's a lot of work to try to, across the province, come to this playbook for 2022. This was the pilot of this. It'll be adjusted from year to year with what we've learned from this past summer, which had several heat warnings declared. Next slide, please. Quick mention of these heat check-ins during extreme heat events. If I could bump onto the next slide. Again, going back to that coroner's report, we know that over half of the people who passed away during the heat dome were living alone at the time. Social isolation has been identified as an issue. I think we'll understand that's been the case in the BC heat event and then other heat events in major cities for decades, really. One thing under this recent found section that really I think is quite impactful to us is finding that half of the people who died were found during a wellness check. So this is either an agency like police or public health or another agency checking on people or family members out of a known concern for their wellness. So this was people who were, people around them or agencies around them had identified some sort of risk and were checking in on them. Another third of people who passed away were found by someone during regular contact. So this is family members going for a regular visit that they would make on a regular basis, but they hadn't identified a known risk, but they were just going in. So we know that a lot of people did have some amount of social connection, and the potential to leverage that to empower people to make checking on people's wellness, thinking of what's the frequency that you want to check in on someone, and what can you actually be asking about during those check-ins, we think is really crucial. And an area of potential benefit. Next slide, please. This has been well described. This is from 2018, National Collaborating Centres on Environmental Health, which is connected to our BC Centre for Disease Control, as well described in reports. They've even made, I think, user-friendly videos on the concept of looking at social connection in terms of its benefit for climate resilience. Next slide. So in talking to non-governmental organizations, some of them social housing providers, some providing services for seniors, a whole variety of organizations had mentioned that they were already doing this sort of work during the heat dome. So this is happening in a variety of settings. Many organizations are doing regular calls year-round, regardless of weather events, just to check in on their clients. And they said that they would like to do this. They're trying to innovate, and they would really appreciate support from government, from public health, in terms of how to do this. They'd also appreciate funding if they're going to be carrying this weight in order to do that more effectively. So this is some of the feedback, that both technical support and also material support would be very important, and being included in the emergency response, not just being recipients of directions to check on people or getting these messages sent to them, but actually being involved more closely in the day-to-day of the response at the tables with city emergency planners, public health, and so forth was something that we heard. So on the next slide, This is just an example of a resource that was created by our team. We called it the Heat Check-in Support Framework, specifically called a heat check-in rather than a wellness check. We don't want to imply that this is something that's for all of someone's health needs. It's meant to be applied by non-healthcare workers, people who have expertise in that person or in that community, but to be able to go in and assess both the person's condition in terms of potential symptoms of heat illness and also the space. Is it too hot, or are there interventions that can be made to cool it down through natural ventilation, like using windows and doors advantageously, to positioning fans, to eventually moving a person to a cooler space or to health services if necessary. We tried to make this as clear as possible. Got a lot of iterations of feedback and consultation to do so. We'll probably try to continue to improve it over the months to come for next season. On the next slide, this is just a really brief description. We carried out a number of training sessions, a number of non-governmental organizations, some social housing providers that Magdalena and team helped to connect us with, basically walking through the content that I just described to you, and then also actually rehearsing this. Because it's one thing, as we'll all know, to read all of this on a piece of paper, another thing to get on the phone with someone, and maybe the response is that they would rather not talk to you. Maybe the response is that that person is in heat-related distress. So helping people to feel the confidence for a lot of those questions that we got. What if I phone the person and ellipse? We wanted people to feel prepared to go into that situation. So we did training, and a lot of organizations then went and fanned this out as well to have their volunteers and their staff carrying out this work. Next slide. A couple of quick resources. It won't shock anyone to know that, of course, public health organizations would put out information like this sort of helpful guidance. The main effort I wanted to describe is just the effort to actually unify and align these. I find that one of the only things that can be worse than no information is a lot of what I call similar but different information. So when an organization, an NGO, is getting multiple messages on extreme heat saying to do similar but slightly different things, we've had feedback that this causes a really chaotic situation, and it actually can cause paralysis for organizations that would like to respond but just don't have the confidence to know that they're doing so in the right way. There's been a lot of work in BC, I think, again, with this sort of heat emergency being new to us, to get these messages aligned, looking at our colleagues in Montreal, Toronto, historically hotter places, to try to get these things right. Next slide, please. Then going forward, and I'll hand things over to you, Magda, just so you know, one of the things that we've developed is climate resilience funding for community-based organizations. When we hear from organizations that they're actually trying to activate some of these wellness checks, using their own spaces as cooling centers, because we know that people might have hesitations, as I described, to access municipal government cooling centers. They might prefer to go to a familiar space where they're already accessing services. And some of these places have said, with the right resources, with enough money for a portable air conditioner and maybe some added staff, we could basically run a cooling center in the services that we're already providing. So we want to try to support that, and that's a new funding stream that we're ramping up in our health region. Improving the coordination. We know that whether it's on a person-by-person basis or a building-by-building basis, there's the potential for duplicated efforts because of the intersectional nature of this risk. Somebody who might be at risk because of their age, maybe because of a known disability or other issues, might end up receiving multiple checks. We want to avoid that for a number of reasons, and also avoid missing out on the opportunity to check in with people who might benefit from that. So looking at online opportunities. Again, Montreal has a lot of good experience with what they've described as reverse 911 calls, where they actually have a large database to support this. This is something that we're trying to ramp up towards in Vancouver. Again, supporting organizations to work on social connectedness, not just for the prevention of heat illness, but for its overall benefit for health and well-being. We could talk more about that. And then finally, before I go to the last slide, just advocating for the so-called right to cool. So preventing heat illness in the first place, not saying, it's good to talk about these cooling centers or checking on people, but better yet, having people in housing that's going to keep them safe, whether that's through a portable air conditioner, heat pumps, better design and the more sustainable design in the first place. As we've heard eloquently from our keynote at lunch, or we all know, this is a human right, and we should really look at it in contexts that haven't had to wrestle with it before. The fact that just the way we have minimum standards for the heating of places in winter, we need to have standards for how a place is cooled off in the summer. On the next slide, please. some work we've done on that around policy. We know that there's so many different, it's not as simple as just saying every apartment or every house will be 26 degrees or cooler or whatever the threshold. There are so many different policies that point at and potentially impact the temperature of a given home during a heat event, whether that's building codes at the national or provincial level, the Residential Tenancy Act in your province, maybe local building bylaws, like Vancouver happens to have its own above and beyond the provincial building code. I won't read all of these to you. I mean, many people in this room are, of course, experts in these different types of housing, but each of these is touched by potentially multiple different regulations, all of which can be amenable to trying to establish this right to a cool space, a climate resilient space during heat events. Vancouver's made a really positive step by actually requiring that buildings will be able to filter wildfire smoke and cool to a certain level. It doesn't have to be through air conditioning. It could be through heat pumps or other means. But the idea is that they'll perform to a level that's safe for the occupant. And this is really, I think upstream of all of these heat response issues that we're describing, really where we need to go in terms of the long-range planning. So I'll hand things over to my colleague Megha. Could I grab the next slide, please? And come on up.
Thank you very much, Michael. That was a lot of information there. Can I have the next slide, please? So my name is Magda Spala. I'm the Sustainability and Resilience Director, and the reason I was asked to present is because I have been working on extreme heat for quite a few years actually with Dr. Schwan. So it's not a new topic. If we go to the next slide. And I usually start my presentations talking about Curtis. So Curtis Brick was an Indigenous man who was unhoused, and in 2009 he died in one of Vancouver parks because of the extreme heat. And it was the first case of someone dying from extreme heat in Vancouver or in BC that has been publicized, that has been mentioned in the media, and it really shook a lot of organizations up, including the city of Vancouver, and they started work on extreme heat and kind of really taking it as seriously as it should be taken. And so while we were focusing our presentation on the 2021 heat dome, in 2009 there was about 100 people that died from extreme heat. So moving on to the next one, please. And so Michael mentioned that it was over 600 people that died during the heat dome. Not many people realize that that's the highest number of fatalities related to weather-related event in Canada. So, there's other different disasters where are very highly visible, but people that die from heat usually die sort of away, they are not seen. And that's why extreme heat is often called the silent killer. And people that die are not the only people that suffer during heat dome, right? So there's many other impacts. I just thought I would mention that. So it's not just deaths, but also a lot of people suffer in different ways because of the high temperatures. We also had a tremendous loss of wildlife and livestock and crops. There's certainly huge impacts on the ecosystems. And of course, probably most of you have heard of the town of Lytton that completely burned out. Everyone had to, there was a few homes that stayed, but most homes got burned. So all those people got misplaced. They are still misplaced. They are very far from rebuilding their community. And, when we're talking about the issue of homelessness, those kind of events, contribute to people becoming more at risk of homelessness. The next slide, please. So here's that table again that Michael already shown you, but I wanted to draw attention to the sort of where we come in, sort of on social housing. So there's a line called SRO, which stands for Single Room Occupancy Hotels, Social Housing and Supportive Housing. We had 62 deaths. And so most of people that died, like Michael said, inside a building. And the reason why, even though the temperatures outside were so hot, unfortunately the temperatures inside can become even hotter because there is a lot of social housing units are very small. Typically there's no ventilation or very poor ventilation, and the temperatures accumulate, so they can become actually hotter than the temperatures outside. And so you see in terms of people who are outside, it was 13 people that died who were outside. Next slide, please. So zooming in on that number of people in social housing, there was some, we do have some private social housing in BC. So out of that 62, 54 deaths were occurred at 46 sites that are funded by BC Housing, so social housing. And 5 sites had multiple deaths. They were big concrete towers that had multiple deaths. And I mentioned the deaths outside. And then you can also see the split of deaths. This is number of people that died within social housing in terms of different communities. So while the highest number is in Vancouver, there was also other municipalities around Vancouver that had high numbers in Burnaby in US, Surrey, and then outside of the Metro Vancouver and other places as well. So next slide, please. I'm not sure how many people in the room are familiar with BC Housing, but we are a social housing agency. We're a crown corporation funded by government, but a little bit at sort of arm's length in terms of how we deliver housing. And we provide full spectrum of housing, so from funding shelters for people experiencing homelessness to housing with support services, low income, and on to the other end of the spectrum in terms of affordable housing. Next slide, please. So what we found is what Michael's already mentioned. So in terms of, a lot of housing, especially for the homeless population, is not as equipped as other buildings. So we find that a lot of those buildings are older buildings with, in urban heat islands, so having that additional effect of higher temperatures. They're also located in places that are far from any parks or green spaces, and that has been the analysis of people that died showed that actually was one of the contributing factors. If someone lived 100 meters or more away from green space, that presented a higher risk. No cooling. Most of our cooling, there's no any kind. Most of our buildings that do not have any cooling. A lot of buildings have the southern and western exposure in terms of windows, so there's that additional heat coming in. And I've already mentioned the accumulative impact of indoor temperatures. Next slide, please. So in terms of how we try to respond during the heat dome and this last year, this past summer, we didn't have a heat dome this summer. However, we did have also unprecedented weather. We had I think, was it 4 heat waves, 3 or 4, 5? We had 5 heat waves. The temperatures weren't as extreme, but what was different, they lasted a long time. There was a lot of conversation around the impact of extreme heat, of a prolonged, when it's sort of a, it typically would be 3 or 4 days, but this year was like, it went for over a week. So, and we are yet to sort of study and understand that a little bit better. So we have activated wellness checks and outreach teams to seek out people who might be more at risk who are outside. We have been distributing fans, and with additional caution of sometimes when the temperatures are too hot, the fans may have a more harmful effect, and Dr. Frank can talk a bit more about that, but they can help in certain situations. So we have been very careful with providing fans as a cooling measure, but we have been distributing those. Opening cooling centers, so both within our buildings and social housing buildings, and directing people to public spaces that were typically run by municipalities, whether that's libraries or community centers or other places. And distributing water, hats, sunscreens, and what was new this year, we also distributed cooling kits, and I'll show you what items that belong into the cooling kits. Next slide, please. So at BC Housing, we kind of have two-pronged approach to working on extreme heat. One is more of the sort of emergency response. What do we do if it's super hot tomorrow? And the other one is longer term, so more focusing on our building design. And when we're doing major upgrades and retrofits, we're starting to now include cooling as one of the priorities. Next slide. So those are some key components of our response plan on that emergency side. So starting with really communicating. A lot of people don't realize how dangerous heat can be. So really communicating that risk and also what can be done to mitigate it. Michael mentioned coordination. There was a lot better coordination this year in terms of us and other agencies, such as the health authorities and emergency management, BC, and other partners that we've worked with, but also within our own organization. We were a little better coordinated this year than we were last year. In terms of who's responsible for what and who communicates and when and all those things. That the alert system that Michael showed, we took that and we said, okay, so when there is a heat warning issues, this is what we do. When there's the extreme dangerous heat warning, then this is what we do. So just kind of really being very clear and prepared and communicating that internally and externally. We have been doing pre-summer tenant risk assessment, so within our existing tenants, we try to pre-identify who might be at the highest risk of extreme heat. And then when the heat event is happening, we do those heat checks that were mentioned earlier. We operate any common areas that we have within our buildings are turned into cooling rooms and have portable air conditioners and also air purifiers. We also oftentimes are affected by very poor air quality due to wildfire smoke, so combining those two. Communicating off-site cooling options when available, and I mentioned the equipment. I'll talk about that a little bit more. And then now we're in the period where we're evaluating what we've done this summer, and it's going to be a continuous. Each year we learn something new, and there's something better that we can do going forward. Next slide, please. In terms of specific response for unhoused population, we do have outreach team that have been going out and seeking out people who might be at risk during the extreme heat events. Cooling kits that I'll show you in a moment. We also have been organizing through and I say we, when I say we, actually we provide funding and we encourage, but it's all the work done by the nonprofit shelter and housing providers and communication. Next slide, please. So this is just an example of one of our tips to beat the heat poster. We had a different version last year and received feedback from a disability consultant of some of the measures. We becoming a little bit more aware how to be a bit more specific in terms of addressing needs of different populations, such as people with disabilities or people who are older. And so this poster tried to reflect that, and we still know that there's a lot more work we need to do on that front. But the poster is used as a big poster and also as a little leaflet that we give out when we do the wellness checks. And sometimes when we do the heat check and someone is not at home, we would leave a card to indicate that we've made an attempt to contact them and then follow up afterwards. Next slide, please. So this is just a few icons showing what's in the cooling kits. I've mentioned that it was the first time we did it. So all those items are low cost. And put together, we haven't done a formal evaluation yet. That's something that's in the works right now. But we have anecdotally received a very positive feedback for, we are not able to provide air conditioning to everyone, but we can, I think we distributed around 5,000 of those cooling kits to people who are housed and unhoused in collaboration. City of Vancouver actually led that initiative. And it was highly successful. I think it just gives people something that they can use themselves and can protect themselves. Next slide, please. And I mentioned pop-up cooling tents. So we try to encourage the nonprofits to create those near where people are. So localize either near the shelters or in other places where we know that people go anyway. And they include all sorts of different items. There's water if there's ability to provide water, or bottled water if not, shading, and again they're having that conversation with folks as they come in. Next slide. And collaboration that's been mentioned a few times now. That I can't emphasize how beneficial that was to really talk to different agencies and try and coordinate our efforts. And we've done great progress, and there is more work to do. Those are some of the agencies that we have been working with, and we've been organizing workshops and webinars, and we'll continue to do so. Next slide. Michael already talked about this report. I also thought it was very informative, so I'm not going to spend too much time because since you have two presenters mentioning, I hope you will get on the website and check it out. It was very informative for us. If we go to the next slide, just a couple of quotes from that report. One was from the nonprofit providers. You know, when the extreme heat occurred, though a lot of nonprofits were already very, very stretched. We are still in times of COVID, and just recognizing that it just provides another layer of additional responsibility, a work for those organizations, and just a reflection of you know how hard it is when you're outside and you try and find shelter that also provides cooling. The next slide. So just sort of high-level recommendations that came out from that report. I'm not going to go through it, just, encourage you to check out the report. The next slide. And this is our website on bchousing.org. We have actually a number of pages that are devoted to extreme heat response. And you can see that there's all sorts of information from sort of what are the alerts to what are the health impacts, how to communicate with tenants, how to create cool space. So again, I just encourage you to check it out. And if any tools and resources that we've developed, we post on this website. So I hope you'll find it useful. And I think that's my last slide. Thank you.
Thank you so much. Thank you, Madeline. Thank you, Michael. In the interest of time, let us go to the next presentation. Welcome you to stay here. We have to the next session. Then we have an opportunity to ask questions after the next
Hey, hi everyone. So I think they're just going to bring up our presentation now. I'll just introduce myself. My name is Kate Franco-Pridham. I'm a research program manager at the MAP Center for Urban Health Solutions, which is based out of St. Michael's Hospital in Toronto. And I work with Dr. Stephen Wong and his team and our community partners. And we do work on housing and health and homelessness. Oh, amazing. Okay, so we want to talk to you today about our two programs, how they collaborated during the pandemic, and what we think this teaches us about what's needed and where we can go next. So I'm going to start out by just talking about some research that we did at MAP and how it led to the Navigator program, which is then the program that collaborated with David's program during the pandemic. So in 2019, in response to research from this research here, we began the Navigator program. This research is called the Readmission Study, and it was led by Dr. Wong and led by our survey research unit, some of whom are here today, I can see. We followed 129 participants when they were hospitalized who identified as homeless. And found out a bit about them and then tracked to see if they were readmitted to the hospital. So here you can see some of the information about those participants. Of note, only about half had a primary care provider, only about half had a caseworker, and then some of them had both. Not a lot had a discharge plan from their hospitalization sent to a primary care provider that they had recently been involved with. And these are just some of the common discharge diagnoses for people who were admitted to the hospital during this study. A lot of people had various kinds of infections. So in that category would include wounds, would include sepsis, sometimes heart conditions. COPD is a chronic lung condition that really affects a lot of people. And you can also see here that quite a few had previous involvement in the healthcare system, and a very high percentage, 12%, left the hospital against medical advice or self-discharged, which compared to the general population is very high. So what we found overall is that 27% of these participants, so of this 129, were readmitted to the hospital within 90 days. And that, again, is a very high number. And this slide is clearly not quite working, sorry. So we found two things. When we compared the group of people who were readmitted and the people who were not readmitted, there were a few factors that we found. One factor that was associated with higher odds of readmission was a high number of medications at discharge. So this was really interesting because it wasn't necessarily that it was a higher severity of illness, it was about the number of medications, which leads us to think that it probably has something to do more with medication management. Then there were some factors associated with lower odds of readmission, having informal support like family, friends, community groups. When a copy of the discharge plan was sent to an active primary care provider, and having an active case manager. Those things were associated with not being readmitted to the hospital within that 90-day period. We also noticed that no one was discharged to housing after their hospitalization. They were discharged, most of them to the street or to a shelter. We had a smaller number that were discharged to temporary housing, which could include like a boarding home, transitional housing, things that were time limited. And then some were sent to a healthcare facility, which means like potentially another hospital. They might have been transferred to a physical rehabilitation center, things like that. So we kind of took all of that information and decided to create this program called the Navigator Program. Fred, who's here and will speak later, as you can see, is one of our navigators. We refer to them as homeless outreach counselors. We now have two. The program is funded by the St. Michael's Hospital Foundation, and it originally started just on general internal medicine, but it is now across all of the floors with the exception of labor and delivery and psychiatry, because those have different kind of follow-ups required. And we're actually just this week expanding to St. Joe's. And we won't go into we will hopefully at another presentation, maybe next year or the year after, be talking about the results of how effective this intervention is. But just wanted to kind of go over that. So the program now consists of Fred and Elisa, who are pictured here, and were recently featured in this Globe article. Myself, I work as kind of a program coordinator on the back end of things. And we also consider our Flex Fund as a key program component, because we're able in that sense to do things like take people to their appointments, their specialist appointments. We are able to sometimes buy small medical supplies, those sorts of things. So Fred and Elisa provide support when the person is in the hospital, they're hospital employees, and then they continue that care for approximately 90 days after the hospitalization. So we do have this ongoing challenge, though, is that the program does not have any housing connected to it or designated shelter spaces that are attached to the program. So we have this ongoing challenge of where someone can recover post-discharge if they're medically stable to be discharged, but they don't have a home to go to. We're looking for somewhere that's physically accessible, close to appointments, restful, where they can stay all day, that has a sense of community and support, and the ideal situation is that there is accessible medical services close by. So the pandemic hits, this program is running. We're even more concerned about people who we know were medically vulnerable, had multiple comorbidities, going back to the shelter. Simultaneously, things were really changing in the shelter system, and that is where David comes in, and we'll talk a little bit about what that was looking like.
Yes, my name's David, and I'm the Director of Housing Services at Dixon Hall. And as Kate, Dixon Hall is a multi-service agency located in Toronto's downtown east. We're a multi-sectoral, multi-population agency with where the Housing Services Department is by far the largest department in the agency. Primarily, up until recently, we have operated emergency shelters and emergency programs in the downtown east. And as Kate said, the pandemic hit, and we grew dramatically in response to the pandemic, in response to the needs of the homeless community in Toronto, in Toronto's downtown east in particular. And in April, shortly after the March, the WHO called the pandemic, we opened up an emergency program at Strathcona Hotel. Strathcona Hotel is a partnership with Homes First Society, and we had 90 individuals. This was a program where we moved individuals from the emergency shelters that we have previously been operating, and they were individuals that we knew would have been successful in housing. We provided them with keys, that we could talk to them about what social distancing was and our expectations around public health initiatives and public health guidelines, and we knew that they would be successful. And that program was the first of the programs that we opened up over a 6-month period. The second program that we opened up is Hotel Victoria, and we're going to speak mostly about Hotel Victoria. Hotel Victoria started out as a program that was very chaotic. We were, I wasn't sure that we were prepared for it initially. There was a large number of individuals who were coming from encampments, the LGBT community from 519, youth primarily, people that we certainly have supported throughout our tenure as housing and supportive housing providers and emergency shelter providers, but not in the concentration that we were experiencing at Hotel Victoria. And then there were people from other encampments and people who'd been living street rough for a long period of time. So you can see here that all of our the 519 is where the initial encampment was. That's the top circle up there. And then we opened up the Strathcona, which is the bottom circle. Then we moved and opened up Hotel Victoria. And it's a site for 55 individuals. And very quickly, we started to hear complaints from the city, complaints from the neighborhood, lots of NIMBYism, individuals who thought, we're seeing homelessness in a different way because the rest of us were home in our houses. The homeless people were not. The homeless people had nowhere to go. And they could point their fingers at Dixon Hall because we were at Dixon Hall, the operators of Hotel Victoria, and speak, we were challenged and held accountable in a lot of respects. These people had a lot of authority because it's located in the heart of the business district in downtown Toronto. And consequently, we received a lot of pushback, spent a lot of time on phone calls, listening to complaints, and with the mayor's office and other people at the City of Toronto. And we were very quickly told that we had to change the population that was living there. Well, that's not an easy thing to do, but it did work. In some ways, it worked in our favor because a lot of the individuals who had been living in encampments found that this was far too distant from their services, the services that would be offered through the 519, and consequently, there was this rapid turnover at that site, and we committed to the people that owned the building and the people that were complaining in the neighborhood that we would make an effort to transition that population from the youth that were living there. I can say that population at that time was a significant percentage, were 25 to 29. That was in 2020, and that was in the midst of early days of the pandemic. As that transition happened, we had a conversation with this gentleman here, and we very quickly managed to work with the emergency at the MAP team at St. Michael's Hospital and move people from that program, and we designated the space at Hotel Victoria for individuals who were convalescing or individuals who were seniors. And this was a unique response and a response that we couldn't have done without the collaboration of St. Michael's Hospital and the collaborative relationships that had been built over the course of the early days of the pandemic. Those were collaborations with ICHA, MDOT, the multidisciplinary outreach team from LOFT, and these were services that we had dreamt of for a long time as long-time service providers to homeless men and women in the downtown east. We had always wanted to have a deeper relationship with the health services team, but really the collaboration with Kate and her team was really really changed the way we perceived of the work that we were doing and also demonstrated to us that we could do this work better. This was an opportunity for us to think about how to support men and women who had long histories of homelessness and were living in a shelter and had relationships to the medical system and the health services, but we really found that this changed the way we navigated the system in the work that we did with the Navigator team. Hotel Victoria is a little boutique, and so this is the population today. Much older. You can see many of them seniors as being 50 years of age or older, and it was a real opportunity for us to think about how we work with seniors, and we brought in services from Dixon Hall's multi-service approach, that working with our seniors department and individual case management. The hotel is a little boutique hotel, and there are currently still 55 people living there. Now we're challenged with what happens after, because these have all been articulated as temporary responses to homelessness in the City of Toronto, and as we move through this process and we get closer to these programs being decommissioned, we want to be able to continue to maintain these relationships that we have built with medical supports and medical systems and case management programs to assure that people are supported in the process as we move through this, as we move to the next phase of this challenge. So there's a lot of reasons why this has been like so effective strategically, and really, Kate talked a lot about the challenges that individuals were faced with, not taking medication regularly. Ours being able to work with Fred and Alyssa was a real opportunity for us to assure that people had the resources and access to the services they needed. Also, we had a dedicated, committed team. So many of them who are here today. Liz is the supervisor at that space and has been really effective in making sure that we build community and supports to the men and women that are there. And it really is incumbent on us to think about what the next phases are. What is the new shelter system going to look like as we transition to these changes? Like, how do we assure that we continue to maintain these relationships with health services, with these other external partners that have been so instrumental and collaborative throughout the course of the pandemic? I think it'll be interesting for you to hear some of the cases. Fred's got a couple of cases that are most significant. There you go.
Thank you, David. I don't know whether you need that.
Probably don't.
So, just quickly to speak about the importance of having a central location like that. I could go to Hotel Victoria and see 5 or 6 patients all at the same bang, 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 bang. Right? It really made my day a whole lot easier. And I would go there at the start when I had good numbers of people there. I might be there 3 or 4 times a week. And it just made it easier to be able to locate them and find them. It's a challenge when you're dealing with unhoused people to sort of figure out where they are, right? And they've got their own private washroom. At the start, we had on-site health services once a week, housing services for their ID, so everything was there. And David was really good about sort of putting all those services in place with his seniors team, and it was really a bonus to be able to sort of do it all at one place. Right? Since we've sort of been limited with some of those services, particularly healthcare. But something that comes to mind is one particular client, a gentleman who was in hospital, type 1 diabetes, and he had 46, I think, and he'd had a long history of type 1 diabetes and sort of claimed it was well managed, but of course medically proven that he wasn't managing it properly. So, of course, he goes, we get him teed up to get discharged. He sees a diabetes nurse educator. I get him, she clears him, says he knows how to take his insulin, everything's good. And then he gets discharged to Hotel Victoria. I take him over, I drop him off, and on my way back, I'm thinking to myself, where's his medication? Right? So I thought I'll just check. So sure enough, he was supposed to pick his medication up on the way out, but he didn't. So he didn't have his medication. So I hunted around, found out where his medication was, brought it over to him the next morning, and so I pulled out, his insulin and everything, and his ability to be able to check what his sugar levels are at, and I asked him to show me. Sure enough, because he kept saying, "Oh yeah, I'm fine. I know what to do. I've been doing it for years. I know what to do." I mean, he couldn't even take the insulin pump out of the box, like he was lost, right? So we were able to put a nurse in place from home and community care, and she saw him every day at a certain time of the day, made sure he got his insulin, right, and did that for I think about 3 weeks until she got him trained to the point where he could actually do it himself, right? So Kate talked about us supplying medication, and sometimes people don't have drug coverage, and we're able to buy medication, right? Or we're waiting for a home OT assessment, and we need a shower grab bar and a toilet riser, and you're waiting 3 or 4 weeks for a home OT to come. We can't wait. We're discharging it tomorrow, and luckily our Flex Fund is able to purchase some of that stuff, so it really helps. I think we've had some really, really solid successes, and using David's programs and housing and being able to house people beyond, and then have them, living what is I think is happy lives and what is sort of content lives. And so it's been really a positive outcome. So, yeah. I've got lots of other stories, but I won't bore you with it.
We'll just say a little bit more about this. Is as we were saying, this is what was happening during the pandemic. Oh, now I'm going backwards. This is our ideal version. So based on Fred's experience there, we think having all of these things and then also adding a couple more extras. So some more home care support, like PSW support, and just making sure that people and home care services and other services can get in there, just like Fred was explaining about the nurse. And then also having hoarding and pest control specialists, because we know that was a big challenge. And the hotel staff has been amazing, but this is an ongoing issue, and we know for very good reasons that people are having these collecting activities, but can definitely pose challenges for their healthcare as well. And then we just wanted to also go to that this is actually what the current state is. So instead of expanding our list, we're actually going a little bit backwards right now. The senior specialist that David was able to bring in has now, that was specific to the pandemic, that's been rolled back. The health services that were on site, that was specific to the pandemic, they've then been rolled back. We're now at 2 meals delivered as opposed to all 3. And there are a few new admissions that are happening, so we haven't had as much luck working with the staff, which is for no fault of the staff, just because this is the situation that we're in, particularly that most of the shelter hotels are actually slated for closure in the winter or the spring, and we're not really sure kind of what's happening next. And that, I guess, leads us to where to next. And we have, I think, a lot of positive things that we kind of came up with, of the things that we think that this has a lot of possibility for. But also, we just want to recognize that, like Toronto in particular, our shelter system is in really rough shape right now. We're having the emergency shelter system, and coming from the hospital side, we're having a really hard time discharging people to anywhere, not just in that first graph we showed to shelter and to the street, but just to the street is a lot of what we're looking at right now, particularly from the emergency room, which we don't work with directly, but we've had an enormous amount of people that, even if they say, I'm looking for a shelter bed, even if a social worker or an outreach worker is there to say, I will help you find a shelter bed, we are still not able to find a shelter bed. We had, in the month of September, the data that the emergency room collected, that there were 55 patients. They had 4 people out of that 55 that they were able to connect to a shelter bed, and that's going through a social worker or an outreach worker. all of those other people, that 51 people, just left the emergency room and went back out to the street. And sometimes after having been in the emergency room for over 6 hours. So this is the state that we're unfortunately in. We felt like it was a really big, amazing moment of promise. And I guess this is maybe a question back to all of you, is where do we go next and how do we pick up this amazing work and the things that happened with Dixon Hall and in Hotel Victoria and bring that forward instead of falling backwards.
Thank you very much for team of Kate, David, and Fred, and I want to say to my friend and my friend as well. At this point, I think we'll take questions from the audience. Your questions. Okay, you're welcome.
Could I ask questions to both presentations? I'll start here, or I'll
So that goes round.
I hear you.
One at a time.
That's right, I'm being greedy. I apologize.
It's okay.
So it's really interesting to hear about the pressure in the community to sort of change the demographics, right? And I'm wondering if that led also, like, to Hotel Victoria, or Strathcona, we were talking about at that moment, to become like from more of a high needs to a medium needs sort of space. And if that's the case, what you thought the effects are of having like programs that end up being sort of focused as opposed to mixed programs, right? High, medium, low, both. The pressures that may lead you to have buildings that are just high needs or low needs or medium needs, and what are the positive and negative effects to them?
You know, just quickly before you say that, this all started because we were discharging these elderly people to the street, and it just was not sitting well with me. And at one point in time, we discharged a 75-year-old woman who was newly homeless to shelter, and I was like, this can't keep going on, right? She had medical health needs. And so I made about 9 phone calls. I called virtually every housing provider in the city, and the only one that actually gave me any response was David.
So, and I'm not sure that Hotel Victoria has ever been low needs necessarily. They're a quieter population because they don't have the same kind of mobility as people do at the Bond, for example, or at some of the other shelter hotels. There's still some really deep challenges associated with primary health needs and so on and so forth. But if your question is, do we need place-based housing and supporting individuals who have like comparable challenges, I think that's exactly what we need. I think we need to be building that when we think about supportive housing, because as the City of Toronto articulates, the transition from responses through emergency shelters to supportive housing, we need to be able to build to meet the needs of people who have the most complex needs, because we know that in the shelter system, we're still the most complex individuals are moved from one shelter to another and never land anywhere.
Yeah, so it's something I'm struggling with, right? Thinking forward, right? Mixed communities versus sort of buildings dedicated to folks of specific needs, right? So like that's really where the question is coming from, and I'm just wondering, right? Because I see advantages to mixed communities, I see disadvantages to mixed communities, advantages to the structured piece, disadvantages. I guess moving forward, right? It's sort of thinking this piece through, right?
Yeah, I think
through the experience that we've had in this piece.
and we're in the midst of that when we talk about the transition of the bond, and I think it's important to understand. It's a really important conversation that we all need to be having. And you know, there's no real clear definition from the Housing Secretariat about what mixed housing is. So I think it's for us as a sector to lead that discussion and to determine what mixed housing is, because we know that if we were to think about a new housing model, we would think about individuals who have long histories of homelessness but that are currently living at Strathcona. They don't have the same complexity of need or the same chaotic behaviors as people living at the Bond or other places. So that could be a mixed model where the population still understands one another and there's still a strong sense of community amongst those individuals.
We'd love to have 2 floors at the new Bond.
Yeah.
That's what we'd love to have. I mean, in the City of Toronto right now, you've basically got you know, the ARC program at Sherburne Infirmary, which is less than 20 beds. I think it's, I don't know exactly the number, but it's less than 20. And Casey House has opened up non-HIV population for discharge from hospital. So these are people that have got, that need a little bit longer in terms of their care. So they might, for instance, they might have a longer term of IV antibiotics. So they can't be in a shelter, you know what I mean? And they need wound care that's additional to what, you know, they can get at shelter. So, you know, would they go to one of these programs for 2 to 3 weeks, right? We could have something like that, or, you know what I mean, to be able to transition people and then move them on to something beyond that. But, I mean, it's ideal, but that's a whole.
That sounds wonderful, but move them on to where?
Well, Christine's
Like
gonna
right
find,
now, that is
Christine's
our
gonna find them all
biggest
housing.
problem. There's like nowhere to move them on after this.
So where the, I have a personal lived experience here. However, I have started working with an agency, and they sent me to, one shelter in particular, which is sort of very, very much respond to the big tent. Probably knows what I'm talking about.
There's a couple of them.
Yeah, well.
3 of them, actually.
Anyway, on Fleet Street, but the thing is, it was only supposed to be the Spice Center, now it's people living there waiting and waiting and waiting. And what's happened is, like you talked about, people being released with dire medical needs, being sent to these places where they cannot be helped, where we were told not to help them. And my heart and my, like, people working there were like, all of our mouths, like, what, this poor woman was sitting there up all night because she was afraid to get into the bed because she couldn't get up on her own, and nobody was supposed to help her, okay, because of the you know, the litigation potential. So, and then it was like, well, why was she sent here? We have no help, we have no PSWs, and then, well, where else was she supposed to go? And this is what's happening, these poor people that are
Yeah.
being discharged,
Yeah.
like you say, right away from the hospitals, with no place that's there for them, like, aside from.
The problem,
Just here now, I had no idea what this Victoria Hotel, but certainly, you know, this is really, really bad.
yeah, it's really bad, and the problem is that your loved one is gonna have a stroke and can't get into the hospital because the beds are plugged up.
And
Right, like, that's really the truth of the reality of it, right? That's why they're moving those people on, because we're a crisis, you know, the unit I work on, the 14 General Internal Medicine, that's a crisis care unit, right? I mean, we transition people out all the time, back to home, right? And give them their discharge paperwork, give them their scripts, give them their, you know what I mean? And you're gone, like, you don't stay long if you don't have to, right? And it's brutal, I mean, believe me, I see some of the people we discharge, and it's heartbreaking, right? And, you know, luckily, if they can get connected to us, you know, we can sort of help with some of that stuff. But something as simple as a PSW, for instance, right, home and community care, there's not enough of them, so they can't schedule them in time. Or something happens in the discharge, they don't have the right phone number, they don't, so let me give you an example about how difficult it can be. The home and care coordinator that coordinates that visit has got to get consent from the patient once they're landed where they're going to live. Okay? Now they're homeless. How are you going to do that? How are you going to do that, right? So they can't schedule a visit until they get that consent. They can do it verbally, but they can't do it until, right? We used to have them embedded in the hospital. We could get it done, and of course, in their infinite wisdom, they took that out and put it all into community care. So now you can't, like, but we can facilitate that, right? So if they're connected to us, then we can, you know what I mean, we can make sure, right? I've got a guy that's being discharged from the Sherburne Health Center on Monday to housing, and it's all in place, like everything's in place. He'll go in there, I'm gonna meet the OT at noon, he's gonna have his PSW, like everything's in place, because I know this guy, and he's been homeless for years, and you know what I mean, if we don't get everything in place right away and get him in a routine, it's gonna fall apart on him, right? So.
I'm just wondering if there could be some type of, you know, there's like, you know, information literature that's placed at the shelters to say that there's someone they can call, you know, to discuss it at least, to have, like, we need to have phone numbers to talk to people so that, you know, these poor people aren't just being left to their own devices and
It's a resourcing challenge, you know. And when you speak about Fleet Street or Lakeshore or Liberty Village, those sprung structures came about as a response to a weather event in Toronto, like in 2017, when the temperatures dipped below -30 for a 3-week period, and all of our community centers were filled, and city managers were out working those spaces. So that was the response to an event similar to what happened in BC. But now they've become ostensibly permanent fixtures in the emergency shelter system.
And just one more thing to add to that, which I think also really relates to what I was thinking about during your presentation, is that with resourcing and these systems, it's that housing and health are being treated as totally separate systems. And yet you're having like heat situations where the health and the housing are intricately connected, and we're having where we can't discharge somebody there's an assumption that they have a home, that the whole healthcare system is set up so that, oh, they're medically stable as long as they have a home, but nobody says that part. It's just, oh, they're medically stable, so therefore our health system's in so much stress, we have to move them along. And in the case of someone who's homeless, there is nowhere to move them onto. And what Hotel Victoria allowed us to see was like, just really not a medical system. It was an alternative to a home. It was more of it was a private room with an accessible washroom in an accessible space where home care was not afraid or unable to find or unable to connect. And that was really very simple and made an enormous difference in the people that we saw.
And stable staff teams too. Like one of the things that Hotel Victoria.
No, we can't really continue it because
There's no space.
the shelter system is
We're
in
done.
such a crisis that we were in a moment where Dixon Hall was able to give us that flexibility. They were under pressure to change their shelter.
Which has worked.
And the city was expanding the number of spaces in response to the pandemic. Now we're in a situation where the city is contracting their spaces, and they're not under pressure to change their shelter. So we don't have that kind of flexibility. This was an exciting moment where there felt like more potential.
I've got personal contacts at almost every shelter in the city, and the housing providers in the city, and so I can usually sort of finagle kind of a back door or somebody that I really need. It's all closed. It's done. I can't get anybody anywhere. We're done.
And this is,
Except for Monday. Except
November
for
2nd.
yesterday at Dixon
Except
Hall.
for Hayden.
Thank you, Hayda.
But David's also right about the staff. I mean, listen, Elizabeth and her staff have been, like, it's just been phenomenal, the work they've done. Incredibly, and I'm in every shelter, and in every respite, and in every space in the city, and it's phenomenal. I mean, just the care, and it's wonderful.
And these shelter hotels have demonstrated the value and importance of community, and if I use the bond as an example, what started out as one of the most chaotic experiments that we've ever engaged in has settled, and people have nested there, and they've found themselves at home. But now we're in the process of decommissioning. In the case of the bond, we're actually transitioning that space to permanent supportive housing. But that process in and of itself means that there will be individuals displaced again, and the challenge is where do we move those individuals to?
Hotel Victoria in this case was used in the pandemic because of the pandemic, but it's my understanding that in Toronto, there are several hotels that are occupied by homeless communities.
So, in the shelter hotels continue to function as emergency shelters. They have always been articulated as temporary responses to the homeless situation and to the pandemic. Your question is, like, what's different about the population in Toronto, or?
No, I was wondering if the population that live in hotels, I'm sorry if this question was some possible. If the community in Toronto that live in the hotel, are they visible? Are they part of the homeless community? Do they count, or are they invisible?
They're very visible, and they are individuals mostly who've come from encampments or from the emergency shelter system. So they are counted in SMIS, which is our shelter management information system, and they are very visible, certainly to the neighbors that are very conscious of those people. So they're not. I mean, some of the people that have come from the Navigator program are not people who have actually shown up in the SMIS data, though that would mean that they would have brushed up against the emergency shelter system in some form or another. But most of them are individuals who have histories of homelessness and they're accounted for, if you will, in the shelter management information system. So in Winnipeg, you're saying that these are often that people living in the shelter hotels are not individuals who were previously understood to be homeless?
They are not the federal, the provincial government does not want to know about the conditions that's going on in these buildings, but the conditions that they live in are below what shelters provide.
I think, so this was a direct response to COVID. The city recognized that living in communal settings with 200 men in one room in bunk bed settings was not suitable for COVID. So they went out and rented a bunch of these hotel programs and then got people like Dixon Hall and Homes First and some of the other housing providers to manage them for them. And then those people that already moved out of shelter, a lot of them into encampments or other spots, and then so a lot of those people came and were put into this hotel programs from those locations.
What a comparable situation in Toronto might be is the SROs, which are the single room occupancies or rooming houses that exist outside of the core of the city. In the core of the city, rooming houses are legal, but beyond the core in Scarborough, Mississauga, and beyond downtown Toronto, they're still illegal. And that'll be one of the biggest fights moving forward of the Housing Secretariat to legalize those rooming houses so that they're considered a viable response to the homeless crisis.
So they're inspected, which I think really.
And they're being inspected, yes. Yeah.
And last question.
I just wanted to ask what the success of this partnership you think maybe suggests about the possibility of more permanent place-based integration between these two services. So I'm thinking actually housing of community health hubs or hospital outposts and the work that is within shelters and having more permanent partnerships that look like that.
Well, I can tell you, I've started advocating in our hospital to get more involved, but it is like this sector issue that's really tricky of the housing side is even housing and shelters are separated. So for them to say, okay, well then, where do we fit in? And does the hospital really want to get involved? Or the healthcare system in general, not even just the hospital, really want to get involved in providing what they see as housing or somebody else's domain. And so I think that's where we need to do a lot of work. And I am open to all suggestions of how we can start doing those bridging, because other than just talking about how great it is all the time, that's a bit where we are.
You're certainly seeing navigator positions opening up in other parts of the hospital. You're also seeing them in shelters, and you're seeing health navigators. The problem in there, one of the best parts about our jobs is we're hired directly by the hospital. So I've got all the access, right? I've got all the information, right? So with consent, I can look up, so that, Elizabeth can call me from the hotel, and it might not even be my client, and I can speak to the client over the phone, get consent, and look up what, yes, they actually have an appointment on this date they need to get, you know what I mean? So it becomes a dual partnership back and forth.
But it's a good question, Maddie. It's an opportunity for us to think about what the new supportive housing models look like, how we embed, like we have these embedded services in these shelter hotels, and they're not services that we've had in the emergency shelter system for decades, and we have always wanted them and believed that is what would support and promote the health of the men and women that we support. So, if we're going to continue to, and if we advance the notion of housing as a human right, we need to make sure that we support some of the most complicated cases in the city of Toronto, and they're going to need access to medical supports. They're going to need access to a range of supports, and embedding those services in a new supportive housing model is